At a time of significant financial pressure facing the NHS and when foundation trusts are taking more responsibility for education, training and development, how can boards be assured they're going to get a return on the money they invest in training and development?
Well, I'd say two things. I think first that you need to be really clear about where you're putting your investment in and why. So asking the question about whether or not it's provided good value for money assumes that you're really clear about the level of investment you're making and why you're making that investment. So being clear about what the development and training needs are for your organisation, where the pressures are in your organisation, where you need particular interventions, so that following up that conversation with the and why did we do it, and did we secure an appropriate return is easier if you've got purpose behind your investment in the first place. The second point is that although it's hugely important that boards are assured of how that investment is being spent, it's useful to remember that not all industries are as interested in the return on investment question around leadership and management training as the NHS is increasingly. There is a sense of having invested for a long period of time and seen the results of that investment by better, more qualified, more experienced and expert leaders, they trust that investment to be working.
Okay. Do you think it's right that the NHS should have some measures to understand its success in this investment?
I think as long as access to and provision of training and development remains discretionary in the way that it does, the more that we are able to clearly articulate the difference that investment can make and the impact that it has on patient care and patient outcomes by doing proper, thorough, robust ROI investigations, the easier it will be for us to argue for their more consistent and more comprehensive investment.
Yes, you did. It brings me on to another question. You mentioned in your presentation that whether people have access to training and development is a matter of geography and opportunity. Is it inevitable in an industry the size of the NHS that there should be that variation? Should more be done to ensure greater consistency in access and the content of training and development?
As long as it remains that it isn't a requirement to have management or leadership development before moving into one of those roles, either from a clinical professional background or from any other background, then there will inevitably be real variation in the kind of support that people access. I think responsibility sits at 4 levels. There's an individual responsibility, so there is training, development and support out there for you should you need it. There's an organisational responsibility. The organisation does have a responsibility for the development of its staff across all of their professional expertise. Increasingly we look to systems and local health economies to help people train and develop together. After all, they're delivering care together, so it makes sense that they learn together. And nationally, I think we have a responsibility to make clear the difference that effective leadership makes to services, therefore the importance of leadership development, and therefore the requirement that there should be on leaders to make sure that they've invested in themselves.
In the context of the Mid-Staffordshire situation, Karen, what aspects of management and leadership development do you think have got the greatest potential to make a difference to better quality care and patient experience?
That's a really good question and a very difficult question to answer because it is so much contextualised, isn't it, by what the organisation needs at the time, by the individual, by the team, by the environmental context that people operate in. At the moment, we're spending a lot of time nationally investing in helping leaders understand their personal impact on those around them and being very conscious of the decisions that they make as a leader at work. And I think that increasingly is providing really helpful interventions to people. Acquiring knowledge, developing skills, developing through experience is relatively easy to access in lots of different ways. Spending time reflecting on your personal practice as a leader is much more difficult, and I think people need help to do that.
In your paper, you cite the chief executive of Tesco's, who said that the key to his organisation's success is that people from every rung of the corporate ladder take responsibility for leadership. You've got to empower people to take responsibility. That's really is the kind of leadership that works, that Terry Leahy says. Do we have that sort of culture in the NHS? And if not, how can we prepare leaders and managers to both give and take responsibility?
The answer is that yes, absolutely, we have it in pockets. We don't have it universally. And I think if we accept that leadership at every level in the organisation and across all professions really does make a difference to patient care and patient outcomes, then we need to take that really seriously. And I think quoting Terry's statement it reinforces that if that makes sense in businesses that are important, but of course not important in the way that the health service is to our population, then surely it has to make sense to us. And I think we can do that in two ways. One, by constantly holding the conversations. What you measure, what you talk about, what you regard as important will change people's behaviour. And secondly, I think there is room to discuss whether we build in more clarity around what we expect from leaders. Should we include in all job descriptions for leader roles minimum standards that we would expect people to have developed through, as an example? And I think now is a good time to start that debate and conversation.
Karen, thank you very much for your time.
Thank you, Sarah.